gives me great pleasure to welcome you all to our clinical echo session this afternoon. And thank you so much, everybody, for making time to join us this afternoon. Just encourage you, if you haven't done so already, just to say hello in the chat box and to just add your name of your organisation for us. I do hope that since we last met in July that many of you have had a chance to have some relaxation and some holiday time. And if you haven't, that you may have that coming up soon. So you're very welcome this afternoon, and we really do appreciate your time in joining us. If we can ask you, if you haven't done so already, to register to receive the link to the clinical resource page for this session. And please do ask your questions in the chat box too. If we can't get to answer all those questions today, we will be collating them and we will come back to you with those questions. So please do use the chat box for that exchange of information today. We'd really encourage you to do that. So we have a really fantastic programme this afternoon lined up for us. We're going to be coming across to Professor Max Watson to hear about the current COVID-19 updates. We're then going to turn to your questions, some of our thoughts, and we're going to go to Professor Kate Fleming, who's the Head of Research and Clinical Innovation at Hospice UK. We're then going to hear from Professor Irene Higginson with an update about the COV-PAL study from the Cicely Saunders Institute. And we're also going to be hearing from Dr. Lucy Selman from the Oxford Centre for Evidence-Based Medicine. We are going to be focusing and giving some time this afternoon to think about rehabilitation. And we have Rebecca Tiberini, Director of Wellbeing Services, joining us from St Michael's Hospice. And we're also going to be thinking about developing better together day services for a virtual environment. So we're really looking forward to hearing from Angela Gill, our colleagues from Overgate Hospice. And we're going to be hearing from Chris Kradansky and Derek Maffeo from Dorothy House Hospice. So a really exciting programme this afternoon for us. So if I can come across to Max, I can see Max.
Thank you very much indeed. Thank you very much indeed, Anita. Can everybody hear me?
Max.
Can you hear me okay? Can you give me a thumbs up? Can you hear us? Yep. Lovely to see you all. We weren't sure how many would turn up on the 19th of August, and it's great to see you all here. So thank you for coming. A lot has happened in the 5 weeks since we last were together. A lot has happened structurally, and a lot has happened in the science and in the literature, as we shall see. And today our focus is really being on day services and how we take day services forward in the time of COVID and rehabilitation as well. So really looking forward to some excellent speakers. We've pressed them all in, so those poor speakers have got to compress all the wealth of stuff that they want to share into short time. So we encourage you, please use the chat box. Please ask your questions in the chat box if there isn't a time for full chat today, and we'll really do our best to get back to you to keep going with this really important learning loop. But at the beginning, we've got to go back to why we're here and what's so important. Since we've met last, over 1,740 people have died from COVID. And as we say, these are us, these are our patients, these are our family, these are our colleagues. And we pause just to light the candle, as we do each time we meet, in memory of them and in memory of why we're here, why we're here. Okay. This is approximately week 22 of our COVID. I think this is our 15th or our 16th COVID update. It's been a time of many testing. We're now up to 14 million tests across the UK and 318,000 positive tests. This has been the the week of A-levels and of GCSEs, and eventually UK catching up with Scotland and saying sorry and all of that. It's been the week as well when Public Health England has been displaced. And yeah, I don't know about you, but it just makes me feel a little bit uneasy that we're making such major changes at such a crucial time. And this is the change that we're seeing with Baroness Dido Harding of Talk Talk kind of taking over as interim CEO of the National Institute of Health Protection. Yeah, so that is some of the stuff that's happening across the world. This was back on the 8th of July, 11 million people infected, 540,000 deaths. 5 weeks later, we've almost doubled to 21 million people with COVID and 771,000 deaths. That's 10 million more deaths, 10 million more infected, and 230,000 people more deaths. We see where that is South America really taking off, and the states continuing to rise in numbers. India as well, and Africa, big numbers. This disease, I guess we've kind of become almost a little bit complacent, but across the world, there's no opportunity for any sort of complacency. When we look at what's happening with our excess deaths, UK is still about the same, about 45% excess deaths. That was the same as it was a month ago. Germany, still only 5% excess deaths. Norway, no excess deaths. And the States are rising slightly to 23% excess deaths. And if we look at where the deaths are most, that's in cities where there's lots of people living really close together. In Ecuador City, 248% excess deaths. In Manaus in Brazil, 153% excess deaths. London, 91% excess deaths. A disease of people being close together in warm environments. And into our COVID update, I'm really fortunate this time to have had so much help from Jamila Hussain. As you can imagine, preparing these updates is a labor of love. I've learned an awful lot in the process, but it's just been fantastic to have a partner this time out there scouring the net for articles and of relevance. And we're very fortunate, if we're good, that the Jamila might actually do some of these updates in the forthcoming echoes, if that would be all right. So epidemiologically, there's been a change in how COVID-related deaths are accounted for. Now we're looking at COVID deaths are deaths where people have died within 28 days of the first positive specimen. The other categories are between 28 and 60 days of the first positive specimen, and 60 days, over 60 days. So why did they make this change? This wasn't mandatory in any shape or form. It was trying to get on a level terms with the other countries across the UK. There's an article there about why the death rate has changed. And it allows us to compare more, but also to get more up-to-date information of what's happening now, which is really crucial. Our biggest conundrum that we're going to be looking at today is the growth in the number of people diagnosed with COVID. Just a couple of days ago, the 7-day average was 945. It's already over 1,000 people. So that's a big shift, and that's really worrying. But at the same time, look what's happened in University of Leicester Hospital, where they had the spike, was it 6-7 weeks ago? Their beds, their admissions to their beds have gone down. And East Lancashire, again, a spike just a little while ago, but there hasn't been a corresponding increase in admissions to the hospital or to ICU. So something strange is happening here. There are not yet any signs of a second wave in the hospital data. So what is happening? Remember this picture from Bournemouth and all the worry at the Black Lives Matter and the funeral in Belfast and all those times where people were getting together, and we're kind of really worried this is going to lead to a huge spike down the line. This was on the 21st of June. At that time, in that part of Dorset, there was 1.3 cases per 100,000 of the population. 1 month later, when you would expect this would have had repercussions, this had increased to 2 cases per 100,000. To put that in context, the coronavirus rate in Leicester is currently 70 cases per 100,000. So maybe it was the air. Maybe it was, they're all young people and we don't know that they've actually got COVID because they've not been tested, or maybe they've gone to Turkey now on their holidays, who knows? But there hasn't been a corresponding rise in hospital admissions. So why is this? Could it be that it's too early yet to see the impact? Well, Leicester was quite a while ago, and we haven't, and if we think about the significant Asian population in Asia with people living cross-generationally, we haven't seen it. Why is it? Most of the positives now are less than 45. That's true. So there's going to be fewer hospitalizations because sicker people aren't, more vulnerable people aren't going to get it. Maybe that's contributory, certainly. There's this rather grim idea that the susceptible people, I mean, that population which are close to the edge are now deceased. And could that, and it's hard to believe that because the current prevalence rate we estimate is 6%. So to have all your kind of on the edge people in that's not the right. What about acquired community through T cells? Have we been sharing our immunity? And there's no evidence for that. Is it, and this is going to sound like Donald Trump, is it we're testing more so we're picking up more false positives? Could it be that the tests are picking up little particles of coronavirus as opposed to the full thing? Or we're picking up, our tests are so sensitive that they're actually picking up clinically irrelevant virus? Or is it that people are just staying at home because they're too afraid to go near a hospital, so we don't actually know the true picture? We don't know. But it's good. It's good that the hospitals aren't getting it. That's good. Pharmacology, moving on to pharmacology. And we've got to use these words again: remdesivir, hydroxychloroquine, and yeah, we haven't mentioned dexamethasone. I'm sorry about that. But remdesivir, the guidelines have been produced with some weak recommendations as its use. We're awaiting some really more useful data from the Solidarity and Discovery trial results. Don't hang your hat on this one, as we've talked about. Both the Recovery and the Solidarity trials have dropped hydroxychloroquine and the HIV drugs, ritonavir and lopinavir, because they've been shown to have no effect. Study coming through that methylprednisolone probably was increased with ventilator-free days and a higher probability of extubation earlier, but we need randomized controlled trials. And then there's this new drug, or this drug from Southampton, which is a interferon beta inhaled medication, which they've been pushing forward in COVID as in their study of 100 patients, demonstrating some improvement in discharge from hospital and some decrease in breathlessness in the people who've taken it. But as we've said umpteen times before, you need the proper randomized control trials before you start jumping up and down, or even raising a wee flag at Downing Street to say we've cracked it. Moving on then to clinical issues. Clinical issues. Asymptomatic cases, this is the big burden, isn't it? This, you or I could have COVID and we don't know it and we pass it on to people. And does this mean that, because there are asymptomatic, so much asymptomatic cases around, should we be swabbing our hospice staff on a weekly, regular basis? Would that be helpful, or would that be not helpful? Or would that just pick up irrelevant disease, or what? We need to unpack this. 3 studies that Jamila came up with in Italy, the Veneto region, it swabbed 86% of the population. That's over nearly 3,000 people. 42% of those who tested positive were asymptomatic. Similar sort of study in Spain, 35,000 people randomly selected, given questionnaires, antibody tests, immunoassays, more than 66,000 people responded, that's 75%, and 22 to 36% of those with antibodies were asymptomatic. And then in UK this month, more than 120,000 people, randomly selected adults, given antibody tests, questionnaires, 87% responded, and the prevalence rate was 6%. It was increased to 17% in the British Black population. And almost a third, 32% with antibodies were asymptomatic. So a third of people may be asymptomatic, walking around, who have had or have the virus. So how significant, what's this all about? How important is this? Well, we need to differentiate pre-symptomatic and asymptomatic. Pre-symptomatic is actually more worrying because they're the more infectious. The asymptomatic are, we just don't know. And the asymptomatic may be asymptomatic with a stack of antibodies and T cells on board mitigating against the virus, or they may be long-term viral secretors. We just don't know. And it remains unclear how often and to what extent asymptomatic and pre-symptomatic transmission contributes to incidence, which is why the government are really pushing the importance of test, trace, and isolate. But is it just a little bit of a mixed message? We've got to test, trace, and isolate, eat out to help out. Am I seeing a disconnect here? I'm sorry, maybe I'm just a grumpy old man. Well, that's true. What about antibody testing? What about antibody testing? Really interesting. Well, I think this is really interesting. Cochrane Review, 54 papers, 16,000 people involved, but many of these tests were people who had the test done on them lots of times. I say done on them because most of them were in China. And they arrived at a sensitivity of 90% for those where the test was done from day 14 to day 35. And that sensitivity came down to 70% if they were less than 14 days. It takes time to build your antibodies. A specificity of 98%, pretty good. False positive rate 5%, false negative rate 2%. That sounds pretty good until you realize that you're kind of doing, we want to do 400,000 tests a day. 400,000 tests, 5% false negative, that's thousands of people. Oh dear. Yeah, so what value is antibody testing? I think it's got a real place in the role of the individual in one kind of circumstance, and that's in the person who's had symptoms of more than 2 weeks, but has avoided for some reason being swabbed. Then the antibody's got a particular place to play, but mainly the role of antibody is in population studies, because it's useful at a population level to let us know how much response has there been across a population. UK has committed itself to the Roche test with a sensitivity of 84%, a specificity of 87%. And you know what? If you got an antibody test from Roche and you were told, 84%, 87% chance that this is the right result, would you sleep confidently that night? So it's not so good for individuals. It is a population tool at the moment. And this is what we're kind of heading towards in terms of swab testing, the nudge test and the LAMPOR. You're going to hear about these words over the next few weeks. Nudge test, nasal swab, rolled out in care homes and NHS hospitals. No word yet about hospices from September on. A nudge box analysis can do 15 samples a day. It's been evaluated in hospitals across London. Those tests were done back in April time. Interesting. We'll talk a little bit about it. I'm really much more taken with this one, the 90-minute LAMPOR test. It can work on saliva, so it's much easier to get a regular sample. It's not so dependent on proper swabbing. Desktop machine could do up to 15,000 tests each day, giving you a result within 90 minutes. A portable machine could do 2,000 a day. And really exciting, it can say, you've got COVID or you've got seasonal flu. It can differentiate between the two, because that was one of our really big worries, that people get a temperature, we don't know whether it's seasonal flu or whether it's COVID. This machine could differentiate, but there's only one problem, and it's the problem that we've had repeatedly throughout COVID. There's no published evidence to support that it actually works. It's not on the main international list of approved tests, and yet almost 450,000 of the new Lamport tests will be available from next week in NHS laboratories, with the government promising millions more tests will be rolled out. We've kind of been here before. It's so exciting, but is it really real? Is it, you just want a wee bit of evidence, wouldn't you, before you kind of roll that out? I would anyway. But the DNA nudge test, as I said, it was tested across only 400 people. 10% of the results were invalid. That gives you a sensitivity of 83%, or a false negative rate of 2.7, a specificity of 91. It doesn't differentiate between winter viruses and COVID. And in the light of all this, the Royal Statistical Society have been called into battle to set up a working party to produce guidance on what data is needed before a test for an infectious disease is approved. And setting up a working party doesn't sound very dynamic, but we kind of need to work out just what a test result means. The Daily Mail knows what the test result is, but the science isn't black and white like that. It's much more nuanced. If we look at this, if we've got a low community prevalence, as we have at the moment across the UK, even though it is rising, and we've got increased testing, we're going to have increased risks of false positives because we know the virus can be shed over a long time. And we know that the PCR test is based on, discovering a very small amount and then repeating and replicating and multiplying and multiplying and multiplying. And if you multiply enough and you can prove, yes, we've got it, the virus is definitely there. But if that multiplication has taken 4 or 5 cycles, that's a kind of a different result from the result being positive after just one cycle. But all we get is a positive or negative. And so some people are saying we need to get a kind of a cycle result, letting you know just how positive it was, because some of the positivity may not actually be clinically relevant. And this is all about trying to work out the clinical impact of a PCR test. Yeah. So, cycle thresholds may be something which come into common parlance, we hope. Now, you may have thought I've been a little bit excited so far today. I'm going to get really excited about this because cellular immunity, I was kind of reassured by this. This gave me a bit of hope. And what did it say? America and the European studies have found that T cells specific for COVID are present even without antibodies. So the T cells are the memory which allows us to trigger an immediate response if we're exposed to that same thing again. And it's also really interestingly, those T cells which are responsive to COVID have been found in blood samples taken many, many months before Wuhan and COVID happened. So is there cross-reactivity with other coronaviruses that people may already have in them, in their own T cells, which are there? And the joy about the T cells is that they hang around a lot longer than the antibodies. So if we can have a vaccine that produces a T cell response, and just this week, the Oxford vaccine were really chuffed to say, we have produced a T cell response. That is kind of good news towards this hope of a vaccine that actually might have a long-term benefit, because T cell responses last longer than antibodies, and a very small amount of antibody can be very protective if it is supported from the commander-in-chief, the T cell in the system. Our testing has been focused on antibodies, but we're now beginning to look at ways to reliably measure exposure and T cell testing to know how protective T cells are and how feasible it would be to introduce T cell testing, because it could be a little bit longer lasting. Okay, take a breath. Long COVID, again, post-viral disease, post-viral fatigue syndrome, post-viral, all the stuff that we've talked about before. A group of healthcare professionals, young, fit, who've caught COVID, haven't felt that the healthcare system has been all that protective of them, and they've set up a group to kind of support themselves. And there's a study looking at 10,000 people who have had COVID, following them up, because we don't know what we don't know in relation to the long-term sequelae of COVID. This is a really useful infographic published in the BMJ on how to manage long COVID. Really skillful and thinking, really helpful kind of schematic of things that we can do to help maybe our colleagues who have got long COVID. Just a few minutes to talk very briefly about quite a few papers, but papers which have changed the narrative. If you're interested, the links are there. Just click on those and you can have a wee look at them. A few sessions ago, we talked about the damage that COVID was doing to kidneys, and our guess was that this was due to microvascular problems. Two studies conducted independently have shown that actual COVID affects the proximal kidney tubule, leading to proteinuria and defective uric acid management. One study done on samples, one study done on autopsies, both looking at around about 50 patients. So not big studies, but the fact that they've come at this from different angles, probably quite significant, that the damage to kidneys is in the proximal tubule. This transferrin issue may be an association rather than causative, but people have suggested that transferrin may be a key element in the hypercoagulability of COVID. But there are other factors. Transferrin does tend to go up in older people, people of a certain race and certain disease type. So there are many confounding factors, but thinking about if you're interested in that. In the past as well, we've talked a lot about the importance of microvascular strokes. Study from New York saying actually, compared with large vessel occlusions, microvascular occlusive strokes are less. So large vessel occlusion following from COVID is more common. And again, we thought that pregnant ladies got a bye with COVID, but a study from St. George's published in JAMA compared the number of stillbirths during the pandemic months with the same months the year previously. And they saw a real increase in rate. So there were 16 stillbirths, 9 per 1,000 births, compared with 2.3 per 1,000 births. Not big numbers, but interestingly, none of the mums had COVID. So the reasons why they had stillbirths may well have been because they were too nervous to go near the hospital when they detected their baby wasn't moving quite as well, or other factors. Again, the non-COVID COVID impacts. BMA have raised this in stark numbers. The BMA estimates that in April, May, and June, in England alone, there were between 1 and 1.5 million fewer elective admissions, between 2.4 and 2.6 million fewer first outpatient attendances, between 274 and 286,000 fewer urgent cancer referrals, between 20,000 and 25,000 fewer patients starting cancer treatment, between 12 and 15,000 fewer patients starting first cancer treatments following an urgent GP referral. Stark numbers of the morbidity that is out there that has still, or we're beginning to deal with, and it's going to be really difficult. Diabetes UK, again, highlighting this similar sort of issue, suggesting that there'd been an increase of 47% of excess deaths in people with diabetes based on the Office for National Statistics figures. So yeah, lots of things. Finally, on towards environmental issues as we go into the autumn, still summer, and hanging on to that, a study from China, 318 outbreaks in China. Only one of those outbreaks occurred in an outdoor space. All the transmissions occurred indoors. And when you think about that picture of Bournemouth and the Story funeral in Belfast, what did they have? They had air in common. And they had a bit of sunlight, maybe not in Belfast, but they had sunlight in common, at least in Bournemouth, killing virus. And again, another study showing that ultraviolet is very effective at killing virus. So as we go in, are we not really in danger of, when we go into small places, into rooms, into the, getting out of the cold, do we not need to think a little bit about our filtration systems, our air systems? They're not that expensive, but we're finding out that people on planes are actually very safe because the air is circulated so rapidly and filtered through the HEPA system. They mightn't be safe in the airport. They mightn't be safe waiting to get on the plane, but actually on the plane, they're pretty safe because the air is constantly. So do we as hospices, is this something that we could look at in terms of thinking of our air circulation and how we could make that a little bit safer? I wonder. There's quite a lot of literature about this at the moment. Masks. This was a kind of a piece of kit put together for £200 to demonstrate, droplets using a mask, and it kind of uses an iPhone as the recorder and a laser making a fog, and then you speak into it and you see how many droplets come out. And the surgical mask and the full, PPE mask and all that were tested. And the worrying thing for me is I'm a bit lazy and I've got a beard, so I was using a bandana. But what they showed was that the bandana actually created more droplets than not having a mask on at all. It was kind of a cheese grater effect, that the spandex, whenever you spoke, it was breaking up your droplets into lots more droplets and spreading them around more. So I've got to stop wearing a bandana. All the others did pretty well, pretty well. In terms of masks, beware after the holidays. They are not such a wonderful thing. And in terms of making your own masks, Norton antivirus are not good mask makers. And so it's kind of sensible maybe not to follow this particular example. Kate, can I quickly pass over to you?
I don't know how I follow that, Max. Thank you. Oh, it's great to be back, everybody. And I hope those of you who've had leave since we last met had good break, and those of you who are going on leave before we next meet, get through your to-do lists quickly and manage to have a good rest as well. So it's great to be back. So we've got some of your questions, just one question actually from last time, and thank you for this one. And it's around this notion of what is COVID secure? What does it mean for shielding staff? And does it mean no IPU work? So I had kind of a quick delve into COVID secure and what it actually means, and it's a very context specific term. And it seems very much that it's the term most used for general kind of non-clinical workplaces. And that guidance was updated on the 13th of August, working safely during the coronavirus. And this was the guidance that was introduced at the point at which Boris Johnson said, yep, you can all get back to work and we'll make sure that your environment is COVID secure. It applies much less, that guidance doesn't apply at all to clinical workplaces, but what that is, what we managed to unearth, this is clinical guidance on risk assessment for NHS staff, and that was again fairly recently updated, and that was produced by NHS employers. And I put this quote in here just to kind of give you a sense of what it's about. It's about this guidance for NHS organisations on how to enhance their existing risk assessments for those particularly at risk or clinically vulnerable in the workforce. And obviously that's NHS organisations, but that can be extrapolated over to hospices. So yeah, quite a context-specific term when you start to dig it out, but it's a term that we're hearing a lot being used. And as we were discussing it yesterday, it almost feels like there's a kite mark you should have on the door, but that isn't going to stop COVID getting in. So vigilance, not the anti-Norton virus mask, but a really good mask and the appropriate PPE in your setting. Thanks, Max. And on to sharing some community wisdom and as ever, learning as much from you as you do from us. And we had this question about making decisions about returning face-to-face or one-to-one bereavement support work, and have people developed guidelines on decision-making in this context. And this question came about where that might occur, whether it's not ordinarily in the hospice, in the community bereavement services own premises, at home, in school, or another community location. So if you've been making any changes and decision making around your bereavement services or other services that used to occur face-to-face and have developed guidelines, could you share them with us in the chat box? I think that would be really helpful. I think it's an issue that many hospices are facing at the moment, and the decision making. So the more we can share and not reinvent the wheel, the better for that one. Thank you. And just a quick look at a couple of hospice responses. We always like to feature a couple. We've got this first one from Compton Care in Wolverhampton. And they've developed a virtual bereavement hub for the South Asian community. And this is in response to increased pressure on people from the South Asian community when accessing bereavement support. And it's run by trained volunteers and offers people a real chance to share their experiences and feelings with others who've also experienced loss and grief. And there's more detail there. It's a great one there. And this one that we absolutely love from St Andrew's Hospice called Hearty Hospice Meals. And we all know that hospices are produce some of the best food around in healthcare settings. And St Andrew's in Lanarkshire is supporting patients and carers who are shielding by providing a freshly cooked homemade 2-course meal 3 days a week, which we think is a fantastic idea, and supported with a grant from Scottish Government Wellbeing Fund. So lovely idea there. That's obviously providing great support to their patients and carers. So just a brief look there at some of the questions. And now I'd like to hand over to Irene Higginson, who's joined us today. Welcome today, Irene, who's going to give us an update on some of the findings from the COVPAL study. So Irene, are you around? I saw you're on the call.
I am indeed. Nice to see you.
And you too, Irene. I'll hand over to you now. Thank you.
So first of all, it's really nice to connect with you, Max and Kate, and everyone who's on this call. And thank you, everybody, for all your collaboration and support in this piece of work, which I think is creating an enormous opportunity for learning. There's many more organisations than those flagged here who've been involved, and we're producing a list of all the organisations that have put those forward. But if we could go to the next slide, I just want to, so the online survey now is closed. It closed at the end of July, and we had a bigger response than we expected, so that was very exciting. So we got 458 unique responses from across the world, and if you look on the right of the side, you can see that there were 264 from the UK, 83 from the rest of Europe, and 92 from the rest of the world, and one respondent didn't name their country, and I couldn't quite figure it out from their responses. And most were from England, 207, but we had some from Scotland, Wales, and a few from Northern Ireland. And if we could go to the next slide, please. Now, one of the really interesting things, which I think the study has needed to grapple with and unpick as a byproduct almost, is the overlap of the different mix of services that people offer. So you have some that offer commonly inpatient palliative care unit, some that offer home palliative care service, some that offer hospital palliative care service, and some that offer home nursing. And we've tried to draw some Venn diagrams to describe that, because you do see a variation by setting of what services have. And what you can see is that the public managed services are predominantly hospital teams, but a few are inpatient hospices or palliative care wards. whereas the inpatient hospices and palliative care wards, home services, and predominantly also the home nursing is offered by the charitable sector. And that's a bit of important context when we see and when we look at the impacts going forward in this. So if I move us on to some of the key results, this is a bit of a busy slide, but it's got some important stories in it. If you start on the top left, we talked a bit before about the shortages that people have experienced. I would say that one of the other interesting things is that nearly all of the UK respondents had some experience of patients with COVID, and a lot had also experienced staff with COVID. That was less so across the world, but what you can see, which surprised me, is that there was a description of shortages in parts of Europe as much as the UK for personal protective equipment, which surprised me because I didn't expect that from the media. But the big thing that the UK has had is shortages of staff. Everybody's had shortages of medicines, not so much. And also the UK has had shortages of equipment. But if you look at the bottom left by management type, then you can see that personal protective equipment across England, Scotland, Wales, and Ireland is predominantly been experienced in the charitable sector. And for me, that's an important message for the future planning. Yeah. And the quotes that we'll share with you later will bear that out. If you look at the top right, staff shortages, this really was not so affected by whether it was charitable or public sector. It's pretty much the same. And actually in Scotland, the public sector was hit more than the charitable sector, but Scotland was hit less by staff shortages than England or particularly Wales. And if you look at the bottom right, it's other equipment shortages. And what you can see there is that actually the public sector was hit more by other equipment shortages, perhaps because in intensive care units in the hospital teams, they were taking all the syringe drivers and a number of other pieces of equipment, and that didn't happen to hospices. So there's an important message about how we work and how the government works in the future with the charitable sector from these things, particularly in relation to PPE. If I go on to the next slide, if that's okay. This is the one by settings. Now here, you've got some overlap because obviously, as I mentioned before, and I showed you at the beginning, there's a relationship between setting type and whether they're charitable or public funded. And that's why we started to unpick that information. But what's interesting is that it's the home nursing and the inpatient palliative care units that experienced predominantly the PPE shortages, but everybody had some experience of it. And everybody experienced staff, medicine, and other equipment shortages. And if you look across the different countries, I don't see that there's a particular pattern that England or Scotland, Wales or Northern Ireland, and the numbers in Northern Ireland were a bit small, they all experienced more or less the same pattern that you can see there. Now, if I move on to what people did, this is so humbling and so amazing, really. Mev has been leading this part of the analysis and Adejoki leading the quantitative analysis. They're both on the call. So here, Mev has looked at the free text comments that people gave and grouped it into the sort of strategies that people had, what sort of worked, what sort of actions people took, and then some quotes. And we'll come on a little bit more to some more of those quotes in a tick. But one of the interesting things in this, as you can see, is that people were reaching out to pharmacists, vets, dentists, all sorts of different people, trying to liaise. It took an awful lot of time, all this chasing of things because things weren't working for people. Finding creative solutions, but it was a massive undertaking. New plans, new ways of doing things, and sometimes huge, massive effort as the bottom right-hand quote says, had to work longer hours and more days of the week, deployed people to do different things. Some people managed to bring in staff from other areas, use different medicines, tried to extend or reuse different things, got things from the community. And if I move on to the specific quotes, if we can go to the next slide. So you can see here that, you know, sometimes people had to dedicate a whole member of staff to social media to try and get responses from things, working with clothing firms and so on. What they managed to do with problems of shortages of midazolam, the medicines, what people did about staff shortages, what people did about how they managed the admissions. And some of this, I would say, had a real toll on staff. So there's a number of other key comments on this, really, if we could go to the next slide. The impact on staff, I think, has been underestimated and not recognised across the NHS, but also across hospices. So fear for themselves, a fatigue about the workload, a difficulty because of not being able to support people in the way that we like, aspects that distressed people locally, losing colleagues, what if somebody goes off sick, and also the whole business of just having to keep chasing these things was a major impact on people. I took heart from the last session that we had that I was able to attend, when Max reminded us that we know more now than we did before. And what I really hope from this study is that our learning is going to help us with that. If we could just go to the next slide. So we're in the middle of work package 2 at the moment, which is data on individual patients. We've got a lot of sites you can see are spread up and down the country and so on. At the moment, we don't have ethical approval to open in Scotland, but if somebody wants to work with us on that, we'd be happy to talk about it, although there probably aren't that many cases there. But we're collecting data on people who are currently in care or been in care when we've got this. And I think this will give us vital outcome information on patients. And then if I can just move to the next slide, which is really the last slide. First of all, I have a huge thank you to everybody. So we're working on 3 main papers at the moment, and they're in advanced stages. So we'll be able to share them with you and Max, Kate, very, very shortly, and with others. And we've already put out 1 newsletter, but we'll put out another newsletter soon. The 3 main papers, one is the impact of the COVID on the palliative care services and staff, and with a bit of an extra emphasis on the shortages, some of the data I've shown you. One is looking specifically at the advanced care planning side of things. So I think that might fit well, Kate, with some of your queries before about what's been happening. We've got some good examples of that. And one is on the innovations and adaptation that service has done. And we have 2 extensions of the COVPAL survey. So Matt Maddox is leading a survey of therapists looking at the rehabilitation side of things. And I think that's really helpful. And that study is now open. So if you'd like details on it, please check on our website, contact the team. And also we've applied to extend our survey into care homes. But a huge thank you to everybody, and thank you especially to Hospice UK and everybody on the call for your engagement and support. And please tell us what more you want to know. We're going to be really busy getting this out to people as quick as we can now.
Yeah. Irene, thank you very much indeed. I think this feels very much like a partnership. It's a different way of doing research. It's this network all together, and you're helping us to answer questions which are so important. But I guess our big drive is, this is really important data to get out before second surge. This is important data for the government to react to, so that we don't repeat the issues that we went through in February, March, April time. And so it's just a fantastic learning loop and a research loop. And it's the way we should be doing it. This is the way we should be doing clinical research, it feels like. And we just hope that you get responsive, receptive ears in whichever organization is going to be in charge of making sure that we get through the second surge well. So thank you very much indeed. can I move on to Oxford and the Oxford Centre for Evidence-Based Medicine? Just a couple of things to feed back to you on. This first one is something which is very close to Irene's heart, getting more people to die at home. And COVID has done that. This is a study from Carl Hennigan looking at the ONS data, and it shows over this past 8 weeks, the number of deaths has fallen to lower than the 5-year average right across the sector, particularly in hospitals, particularly in care homes. But at home, deaths have increased. And I guess that we've wanted that a lot in palliative care world, and it's happened. It's worth having a look at these figures. Want to move on to Lucy Salmon, who's from Bristol University, but has been in charge of the advanced care planning in community during COVID-19, the Oxford review of that. Lucy, can we pass over to you?
Yes, thank you very much, Max. And thanks for inviting me to present today. I'm delighted to be here. As Max said, I'm a senior research fellow at the University of Bristol, where I co-lead their palliative and end-of-life care research group. And I'm here to talk about a review which I led for Oxford University's COVID-19 evidence service on advanced care planning in the community. Next slide. Yeah, this is really hot off the press. So the review went online yesterday. So please have a look on the website, especially if you have an interest in advanced care planning. But I think also more broadly, sorry, can you go back, please?
Yep.
Thank you. But I think also if you're more broadly interested in COVID-19 and in the response, not just from palliative care services, but from within primary care and in nursing home settings. So our research questions for the review were what enables or hinders people in the community to make or update advanced care plans in the context of COVID-19? And then secondly, how can those working in health and social care best support this process? And these research questions were motivated by a recognition, obviously, of the central importance of advanced care planning during the pandemic, as well as, unfortunately, high-profile cases in the media of advanced care planning being done poorly. So, for example, GP practices posting letters regarding blanket do not attempt cardiopulmonary resuscitation orders to certain patient groups. We worked with two patient and public involvement representatives in developing the research questions, and also the core team involved with the evidence review service at Oxford. And we knew early on that there was going to be a lot of evidence in this area and relevant to this topic. And the review for that reason was obviously very much a joint effort. And you can see that we had direct contributions to review from 11 people. Next slide, please. So we conducted a rapid review with narrative synthesis in about 3 months. And the methods are obviously detailed in the report. So just to flag that the search strategy included searches in 4 main areas. The first was advanced care planning or end-of-life communication during COVID-19. The second area was interventions to improve advanced care planning or end-of-life communication. And the third, telehealth and mobile technology for advanced care planning and end-of-life communication. And then finally, advanced care planning or communication and personal protective equipment. We included systematic reviews, original research with patients in primary and community settings, including nursing homes, and all types of advanced care planning intervention, as long as they went beyond just identifying people who might benefit from advanced care planning. And we excluded research with patients in hospital settings or from a specific disease group. And all of the studies and reviews were quality assessed using tools appropriate to the study design. So next, please, thank you. So there's quite a lot of detail in the report, but I wanted to just use the opportunity to flag some of the headline findings for you. So we included 21 research studies and 10 systematic reviews. And we also identified 12 UK guidelines specifically related to advanced care planning during COVID-19, and those are summarised in the report. Our first review question was what enables or hinders advanced care planning in the community. We synthesised evidence in this area, and then we considered it in light of the pandemic. And what was really clear was that COVID-19 has worsened the context for advanced care planning in some ways. So, for example, it's possibly increased fears of rationing of healthcare resources in some communities. There's also challenges related to social distancing, to the kind of huge burden on staff in terms of their time and resources that Irene's flagged. Also concerns about prognostication and the best time for advanced care planning, given that COVID-19 is such a new disease. And again, because it is so new, a lack of appropriate templates and tools that could support advanced care planning. And some models of care, for example, group meetings and group education around advanced care planning, which have been shown in the literature to be effective, are obviously much more difficult or ruled out in the context of COVID-19, where infection control is so important. However, the pandemic also presents certain opportunities. So there's raised public awareness of advanced care planning and its relevance to all of us, given that we know, COVID-19 can kind of strike at any time. It's also increased importance of and attention to IT systems, and prompted the development of new guidelines and templates. And we've all seen, and I think it was nicely described just before this presentation, this sort of rapid shift in business as usual processes and protocols. So there are opportunities as well as challenges here. So the next slide, please. So our second question was around how to best support advanced care planning. And there are 10 relevant systematic reviews with clear areas of consensus in this, in this regard. So we know that the most effective, sustainable advanced care planning interventions target multiple levels of influence. So they don't just consider the individual patient or the individual clinician, but they also consider interpersonal factors and system factors. And then they also consider barriers and facilitators to uptake. So they're very much kind of complex interventions, considering all of the different contextual factors which influence advanced care planning. They involve direct person-to-person interaction with experienced trained facilitators or group education, a structured patient-centered discussion which takes place over several sessions and is integrated into everyday practice. And they include the opportunity to complete advanced care planning documents, but they're not necessarily focused on that, and that might not always be appropriate. We also found interesting and high quality evidence that video and web-based resources are of particular benefit. Particular benefit among people with limited English proficiency, poor health literacy, or from otherwise disadvantaged communities. And there's growing evidence that online advanced care planning can be effective, especially if it's integrated into existing systems which patients use. Now, obviously, these kind of online resources are only effective if the information is credible, if it's accurate, if the systems themselves are user-oriented, free of charge, and use the appropriate terminology. Next slide, please. Now, just a few reflections on the guidelines and resources which we identified. So firstly, it's interesting that almost all of the guidelines are clinician focused. So, there's little attention to some of these other factors that I mentioned earlier on around the mechanisms for sharing advanced care planning, around public education, and, dispelling fears about what advanced care planning might be or imply, and those interpersonal relationships between clinicians and patients, but also between patients and family members. There's little attention to those. And in general, advanced care planning is still very much portrayed as being for the very sick or vulnerable, and something which is in the hands of and in some sense kind of owned by professionals. Now, there are some exceptions, and there are some public-facing useful websites like mywishes.co.uk. And actually, we found the Scottish guidance was much more sophisticated and helpful in terms of what was actually available to the public compared to what's available in the rest of the UK. So another thing which is interesting in light of the evidence I just described is that there seem to be few video and web-based advanced care planning resources. And at the moment, there's no national portal or any kind of integrated system available through the NHS to support advanced care planning. Now, there are pockets of excellent practice and some useful resources out there. For example, there's the Advanced Care Plan resource for England and Wales, which was put together by Dying Matters Wales and Hospice UK, which has some great resources on it. But I think it's there's the potential to really boost this side of things, and to kind of use COVID-19 as an opportunity to turn our attention much more to creating an effective public-facing hub for advanced care planning across the UK. So next slide, please. So the report draws out key implications for clinical practice and for policy, but I just wanted to flag three kind of key recommendations here. The first is consistent and coordinated public health messaging, which can help reframe advanced care planning as routine and normal for anybody who's interested in influencing their future care, and also help to shift ownership to the public, so that it becomes something which is supported by clinicians rather than something owned by clinicians. I think, to help with this shift, we really do need to see investment in an NHS kind of portal around advanced care planning with suitable public-facing resources for the range of different communities in the UK. And then finally, the kind of holy grail in a way would be to have a national integrated web-based system for advanced care planning in which members of the public can create an advanced care plan which links to their medical record. And we have an example of that in Coordinate My Care in London. However, if this is going to be implemented on a larger scale, we really need UK-specific research on this topic and in this area. We don't want to go down the route of something being developed and implemented without having a really firm evidence base that we know it's going to be acceptable and feasible, and trying to overcome some of the challenges that might be associated with that in terms of some communities, for example, just not having access to the IT systems. If these recommendations are all followed through sort of in the future, what we might see is advanced care planning with perhaps less input from clinicians, especially for certain groups of the community. I think there will always be some patients who do require more input, an increase in uptake and documentation of advanced care planning, and also improved patient and family experiences and outcomes alongside potentially cost savings for the NHS. And yeah, please do see the report for further implications for practice and policy, and we're really interested in knowing your thoughts as well. And the last slide, please. I just want to acknowledge the patients, members of the public involved in the study, the review at the Centre for Evidence-Based Medicine who was involved in providing internal feedback, external reviewers, Fliss Murta and Mark Talbot, and my funder, the National Institute of Health Research. Thank you.
Lucy, thank you very much indeed. It's a really useful review at this time. I've been involved with quite a widespread group who are in the process of finalising an advanced planning charter, which aims to do many of the things which you recommend in terms of making this much more a public-facing approach, what matters to me, and to make it much more about life choices. And those life choices begin at a very early age. And if you've never had a choice and taken advantage of a choice early on in life, then it's hard to suddenly become executive in your last minutes. So we hope to bring that charter when it's got approval to the group and get widespread, because just repeating, doing what we've always done with ACP, we will get what we've always got, and that's a very partial uptake, and we need a much bigger uptake. So thank you very much indeed, Lucy. That's been really helpful. We move on. Thank you. We move on into our focus for today, which is Rehabilitation Day Hospice. Rebecca, please forgive me for spelling your name wrong on the opening slide. We welcome Rebecca to us from St. Michael's Hospice in Kent, and Rebecca is part of our Hospice UK team with a real interest and drive and vision. So we look forward to hearing what you've got to say to us, Rebecca.
Thanks, Max. So it's my pleasure to join you today to really refocus you in on the COVID-19 rehabilitation pandemic. And this is really looking at the exponentially growing need for rehabilitation on the back of COVID-19, and to consider what the role hospices have to play in responding to that rehabilitation need. So you'll all be aware that since February, March this year, we have been facing monumentous challenges around COVID-19. And because our area is palliative care, it's easy to become focused in on those that are seriously unwell with COVID-19 or dying from COVID-19. But keeping that in perspective, it stands that around 87% of people that have had COVID-19 are living with and recovering from COVID. And yet, just because somebody hasn't died from COVID doesn't mean that that in itself is a completely positive outcome. And what we're seeing come to light is that many of those people living post-COVID infection are experiencing complications in their recovery and have a growing need for rehabilitative support. So this publication from the NHS in August, early August, looks at the aftercare needs of inpatients recovering from COVID-19. And it tends to focus more on inpatients, but it gives us a flavour and is worth looking at. And these impacts are not just focused in the physical domain. So I think we're familiar with ongoing issues with breathlessness, post-viral fatigue being particularly prevalent, particularly challenging because fatigue is an invisible symptom. We are familiar working with that within the palliative care context of advanced disease, but in other areas of rehabilitation, it's a newer area. Lots of deconditioning with people being less mobile, and depending on how severely somebody's been affected by their COVID-19, some people going on to have implications with multiple organ failure, heart failure, or post-intensive care syndrome. But aside from the physical, COVID-19 is impacting people's cognition, their cognitive function, and coming through with issues around concentration, abilities with memory, and these things can have a significant impact on people's return to day-to-day life, return to work. And we're seeing in older people, delirium post-COVID-19 becoming much more prevalent and quite difficult to manage, quite persistent. The psychological impacts are really around anxiety, depression, and for some people, post-traumatic stress disorder. And these are not to be underestimated. Just because somebody's recovered from COVID-19, having the self-efficacy and the confidence to get back out there into everyday life when COVID is still present is overwhelming for some and significantly impacting people's ability to re-engage with normal day-to-day functioning. So collectively, what we're seeing here is a great demand for rehabilitation for those people post-COVID-19. And some of the question is, who is responding to that, with all of our rehab services being pressured? However, the rehab needs for those that have had COVID actually just represent the tip of a very big iceberg. And the perhaps more hidden rehabilitation needs are indirect impacts from COVID-19. And what we see here is a huge population of people that are shielding at home. And many of these fall into the population that hospices are supporting. So if we look at data on the most extremely vulnerable people in the UK, we're looking at over 2.2 million people that have been shielding. And the most recent governmental data looking at this in July suggested that 60% of those, so over 1 million, are continue to be shielding. And so when you look at this in context against those post-COVID, this is a huge number of people. And what they are experiencing is deconditioning. They are not going out, they're not moving around. And we know it's that if you don't move it, you lose it model where people are getting weaker. And for many of these older people, people with illnesses, if they weren't frail before, then they're having increasing frailty now. If they weren't falling before, they're at risk of falling, and big impact on people's self-confidence. we heard also earlier from Max about the impact on the NHS of people not presenting to GPs, to hospital services, people not engaging with rehab. And if you look at those outpatient appointments, huge, and they fall into the same category. And so we're seeing this big demand for rehabilitation for people that are socially isolated, shielding, people that are presenting late, and a large group of these are older people. And with our services around supporting older people, people with frailty, we have a role in this. And so collectively, you're starting to see the COVID-19 rehabilitation pandemic, this need for rehabilitative, holistic support on multiple different levels. Now, I can't claim the title, the COVID-19 rehabilitation pandemic, for myself, but I do like it. And I would direct you to this commentary piece from Sarah DeBias, which gives a fuller picture of those needs. So the question for us as hospices, as palliative care professionals is, what does this COVID-19 rehabilitation pandemic mean for us? And what is our role in responding to that? And I know many hospices are responding already. Next slide, next. So I think the question is, who should we be supporting? And for me, the starting point is really around, do people meet the referral criteria for hospices? Because I think while hospices certainly have something to add to people recovering from COVID-19, if they've previously been well and independent and working, is the hospice the right place to be meeting their rehabilitative needs? I would say probably not. But for those groups of people that are older, that have multiple comorbidities, that may have frailty, underlying health conditions, a COVID-19 infection may propel them rapidly into a palliative care population. And we absolutely do have a role to be supporting those with serious advanced life-limiting illness. So the challenge for hospices is around enabling timely access. And I believe hospices need to be taking a proactive approach to identify who are those people that have had COVID-19 that might meet our criteria, who are shielding, and who have a palliative care need. And for many of us engaging with GSF meetings, this conversation is a really good place to identify those that may benefit for an offer of rehabilitative palliative care. And some of the work we have to do with our external partners and our referrers is help them to understand what hospices have to offer to the rehabilitation agenda. Because for many, hospices and palliative care services are still very much equated with dying and end-of-life care, when in fact, we have an important contribution to make to enable people to live life as fully as possible. And many of us have rehabilitative teams that would be able to contribute to those people's needs. So hopefully many of you are familiar with this publication, Rehabilitative Palliative Care. You'd hope I could pronounce that by now, published by Hospice UK some years ago, that I co-authored with Heather Richardson. And the message from me is that rehabilitative palliative care remains more important than ever in the context of COVID-19. And I don't have time to go into the detail of this, but please do refresh this. This is available to download for free from the Hospice UK website. But if we have a quick look at the principles of rehabilitative palliative care, very much focused in on person-centered goals and priorities. And this is really critical in terms of how we pitch the support that we are offering to people. Because if you've got somebody that comes into your inpatient unit whose goal is to return home as quickly as possible due to restrictions on inpatient visiting, then that's going to really impact how we come at our symptom control, our psychological support, our discharge planning to fast track all of that to achieve that person's goal. Likewise, if we're supporting somebody in the community setting that's having breathlessness, they are not going out from their home, they're not seeing family and friends in the usual way that they would be supporting, they are anxious, knowing what their goal is, if that's to walk 5 minutes to their daughters down the road, that's really critical for the type of support we're going to be putting in place across the interdisciplinary team. And we know that hospices and palliative care staff can't work in the way that we usually do. So we're not out there providing the face-to-face support or the well-being program or day service support that we normally would. So this bottom point on supported self-management is critical. People are at home and we need to be giving them the support, the skills, the confidence, just enough that we can provide as professionals to enable them to self-manage. And one of the things that I think we do really well in palliative care is rehabilitation and goal setting in the context of uncertainty. That's directly transferable to the context of COVID-19 rehabilitation, where it's uncertain what that trajectory is going to look like because it's so new. But certainly having those open, honest conversations and naming the uncertainty and looking at positive risk-taking, which is really shifting that risk, that fear of COVID, that fear of going out into the community because of COVID, to look at, well, actually, what are the opportunities for getting people back out there? What are the gains from enabling people to take some carefully considered risks to re-engage, to maintain their independence, their function, their quality of life? And so flipping that fear, that risk model on its head is something that we have to offer. So I thought it would be useful to maybe just share with you some of the things that we're doing at St. Michael's Hospice, which is based in Hastings and Rother on the South Coast. Like many services, when COVID-19 hit, we closed down our wellbeing day services program in terms of face-to-face contact. We continue to offer inpatient admissions and a restricted face-to-face community visiting service. But what COVID's enabled us to do is fast-track the diversification of our holistic support. And the key areas that we've really developed are around telephone support, and building on that, moving quickly to video consultations to give that more real-time assessment, being able to see people even if that is online, and moving our wellbeing rehabilitative groups, support groups to online. And I think it's very quick to see online as the solution, and for many it is right now, but we must not forget those people that don't have access. And certainly where we're working in Hastings and St. Leonard's, we have quite a deprived population, and many of them simply do not have access to those online facilities. The other side of that is for older people who may not be so online savvy. Is that a barrier for them? So looking at offline support, and one of our initiatives is our correspondence group, where our wellbeing assistants work with volunteer drivers to have a focus on an activity. It could be an art activity, a nature activity. Our drivers drop that out to the participants in the community, and they work on that over a couple of weeks, collect that back in, bring that together as a full piece of work and share that. So we're still maintaining connection with people without them coming in, without them being necessarily online. So a rehabilitative approach is absolutely threaded through the work of all of our interdisciplinary team. And even prior to COVID, our focus has been for every individual patient around personal priorities and goals. But more than ever, we're then looking at IPOS, what things are impacting or preventing people from reaching those priorities and goals. And we're building in a screen for every contact around, how are people functioning? Are they being active? And something around their social confidence, because that doesn't necessarily get picked up in IPOS. They may be physically able, they may not be scoring high on symptom burdens, but their confidence levels to get out there or to achieve their goals are what's holding them back. And from there, we're able to feed them into online support and multidisciplinary support. We are adopting a public health approach, and that's really around all members of the interdisciplinary team supporting people, taking the time to be a bit of a coach, to be alongside people in talking through their return to life alongside COVID-19. COVID-19 is not going anywhere, and we've realized that we can't underestimate how people are influenced by the media. They don't have the facts, and that's really a barrier, a fear generator for getting out there. And so helping people to understand what the risks are for them and talk them through their first encounter back into society. Across the board, we are seeing this increased need for rehabilitation. We don't have enough rehab professionals, either in hospice and palliative care or in community rehab teams, to meet that. And I firmly believe that volunteers have a huge role to play in this. So looking at your community of compassionate communities, empowerment volunteers, and having them matched with people to be alongside in a befriending role, but also more than that, a coaching role, an enabling role for people if they are looking to do more. But also to support people in terms of distraction engagement for those that are not able to, that are housebound, that aren't able to have contact with people in the outside world. One of the initiatives we have done is a wellbeing support newsletter. This is around sending out to people either by a post or email monthly a range of different strategies around self-management and distraction. And they range from exercises that people can be doing at different grades, mindfulness, relaxations, creative art activities. And this has been really well received, and our patients and families have valued a contact with the hospice, even if it's not face-to-face. And then the other major opportunity is around integrated working. And while we're not providing face-to-face contact in the same way, video consultations have opened up a whole new opportunity for doing things together. So we're looking at where we've got patients where they would have been supported by our physiotherapist and our hospice at home team, an HCA and a physiotherapist doing that joint video consultation. And likewise, with our outpatient appointments, we've opened that up 2 weeks ago, piloting it, have a risk assessment in place, starting it off slowly, but we're finding that people are really welcoming that opportunity to come back in. And a big shift for us, and I lead on wellbeing services and our community nursing team at St. Michael's, is that we have not just sent all of our hospice at home and nursing teams back out to face-to-face assessments. Instead, we're focusing on where we can, inviting those patients and families that are able to come up for outpatient assessments and appointments in the first instance. And some of that is around safety, sending people out into the community. We don't necessarily know what they're going to be turning up to, how many people are going to be there. We've got more control over an outpatient environment. But the other main reason is because it's a more enabling and empowering model, that for people that haven't left their home, if we continue to go out and visit them, we're indirectly reinforcing that need to remain at home. Whereas an outpatient appointment gives people permission and confidence to come up to a safe space, and that may then transform their further engagement in the community. It's also a more efficient way to see more people, and so we're exploring that going forwards. At St. Michael's, we offer rehab and respite admissions. We have found that some people have been less interested in coming in for an inpatient admission, impacted by restrictions on visiting, which we have opened up more at the moment. But one of the things that we're considering, and this is based on an article, next slide, Max, which is from the States, looking at short stay family training programs. This is around not just bringing people in for a rehabilitative support admission, but actually looking at how the families engaged with that. And in the study, it's around having a commitment from a carer or family member to come in for 3 hours a day, to have training and support to enable them as a family to return home and manage, with really good outcomes on discharge from hospital. But if we have the situation where we are needing to restrict visitors again, we are looking at where we've got empty beds, looking at bringing a family member in to stay for the admission with that person, if that makes the difference. So quite a radical thought, but if we've got empty beds and this is a way we could be supporting people, it's something that we're exploring. So just finally, if it's not that we are providing direct rehabilitative palliative care support to people, we need to be thinking about how we are influencing integrated rehabilitation pathways. And if you click on that one, Max, this is where the wider health system is developing rehabilitation support, and hospices need to be around the table for this to make sure that we are known for our rehabilitative offer and that the right patients are on the pathway to hospices that need it, but also because hospices have expertise in breathlessness management, fatigue management, rehab in the context of uncertainty, and we've got a lot to offer to shaping that model of rehabilitation for people post-COVID most widely. And certainly in the South Coast, partners at St. Wilfrid's Hospice have been engaging in that process and really hugely shifted the model in terms of that holistic rehab offer. So many of you will be aware of the NHS Your COVID Recovery website. This gives lots of practical support and advice for people online, one to direct people to, but also they're in the process of developing the next stage of this. I'm watching for it because it's a plan for after the summer, where via this website, people can have direct access to nurses and rehab staff, physios, OT, for personalised assessment and rehabilitative support. And that's something that hospices may be considering our role in contributing to that. Keep going, Max. And next one. So just finally, I think as we're in this new world of opening up day services or not, supporting people online through group programs for wellbeing rehabilitation, let's share practice resources and innovation. So some of you will be aware of this publication from NIHR and King's, gives some really good guidance. Also, Chartered Society of Physio have really good information on phasing back in outpatient appointments and lots of exercises online that can be utilised, videos. Royal College of OTs, great information on managing post-viral fatigue, pacing, energy conservation. And I think we have to just be careful that we don't all recognise the need and all develop our own individual packages of support when there's some good stuff out there already. So St. Christopher's have great videos on managing breathlessness. Let's use those. If your hospice has got great stuff online that we can be using more broadly, having a more strategic approach is going to be a more efficient approach. And then just finally, to echo on from Irene today, colleagues in rehab services for palliative care, physios, OTs, rehab leads, please do participate in the COV-PAL study around rehabilitation so that we can learn from and really map that change in rehab services and demand going forward and be better placed to support rehab needs for this growing COVID-19 rehabilitation pandemic that we're all facing. Thank you.
Rebecca, thank you very much indeed for a very comprehensive and exciting vision of how rehabilitation services could be. Our plan was that after your presentation, we would be asked going to Overgate Hospice and then to Dorothy House for their practical explanation of what they're doing and how they're doing it and actually in fleshing some of that visionary work that you are doing. I wonder, could I be very bold? I've obviously made a mistake in organizing the program in terms of we've had a fantastic hour and a half, but we're due to finish now. And I wonder, would it be possible to ask Overgate and ask Dorothy House, would they be prepared to hold fast to our next echo in 1 month's time? I'm really sorry about that, but
that's fine from Overgate.
Would that be all right? I'm sorry, Angela.
That's no problem.
Thank you. It would be a shame to cut you short or to press you too tight. And Chris, would that be okay from you in Dorothy House? I'm sorry.
Well, Derek, actually.
Derek McPhail.
Fine. It's quite interesting when you're heading towards the end of the session, and we were thinking, how can we actually squeeze this in about 3 minutes? So Max, it's not really a problem, but if you can give us a good 10 minutes for the next slot, that'd be great.
We'll do that. We'll do that. Anita, can I go over to you just to finish us off, if that would be okay?
Absolutely. Thank you very much, Max. Thank you. And we have had a very inspiring session this afternoon. And thank you so much to all of our speakers. Rebecca, thank you so much for your inspiration and your vision, and for sharing the work that you're taking forward at St Michael's Hospice. Really insightful for us. I think it's given us a lot to think about, and some also really practical, useful resources. So thank you so much for your presentation. And very much thank you to Lucy Selman, for giving us the headlines of the Advanced Care Planning Rapid Review. And I think, you know, your particular recommendations, Lucy, really important for us to hear about consistent public health and the opportunities to reframe that, but also to give consideration for the mechanisms for how we share advanced care plans and how we particularly think about that. And again, citing us on the report, so that's something for us to follow up with from today's session. Very much thank you to Irene for giving us that excellent update on the COV-PAL study. And I think for me, absolutely fantastic to see the context and your Venn diagram, so helpful for us, Irene, in terms of the findings and what that means for us, the key messages and the learning, and very humbling to see those stories. So huge thank you. And Kate and Max, thank you so much for, as always, giving us the up-to-date information. And there's been so much we've learned from your session today, and for Kate for sharing the stories as well from hospices, so from Compton Care and the Healthy Hearty Meals, which I think is just a really lovely, inspiring, again, innovation that we've seen, or a project that we've seen. So thank you so much for that. Also really like to thank Hazel and Melanie, who are working behind the scenes to make sure that everything runs smoothly, and Melanie Hodgson, who, as you know, is our Head of Information Services at Hospice UK, and is supporting all of the work to bring together the resources companion, which you will have access to. So the slides, I think, are already up, and I think the resources companion will be available on Monday from 3 o'clock. So thank you so much, all of you, for your time today and for joining us. And we really look forward to hearing from our colleagues from Overgate Hospice and Dorothy House Hospice next time. So thank you so much, everybody. Max, can I pass back to you?
Yes, just to remind us that September the 16th, we will be hearing of the practical side of day hospice and rehabilitation, and also focusing in on the ambulance service. And I will do my best to get our program better organized today, but fantastic speakers. Thank you very much indeed. I've been really conscious in speaking to a lot of people that there's a lot of apprehension out there and a fair amount of tiredness out there. I hope you're getting your holidays, or you've had your holidays. I guess the non-COVID impacts, we've talked a fair bit about those today. And for many, the workload has doubled for senior teams. And so we need the resources to protect ourselves. And these are the 6 resources I wanted to leave you with today. The resource of when is good enough, about sharing responsibilities much more, about working collaboratively like we're doing today in this collaborative community, letting go of the unnecessary, like the Feng Shui lady who just kind of lets it go. We don't need to fill out that form again and again and again. Planning your breaks through till Christmas. This is called the Tarzan approach, swinging from holiday to holiday as you go through until Christmas time. And then managing energy rather than managing time. If you're doing twice as much work, you're going to get tired. And you can beat yourself up because today you don't really feel like doing it, and today hasn't been a productive day. But if you look at what you've actually done over this last month, yeah, manage your energy, both output and input, as we go forward together. Want to finish as ever with a poem. This is a poem written by the Irish poet John O'Donoghue about his mother, to his mother Josie. And it's in a collection of poems to junior doctors in Scotland. On the day when the weight deadens on your shoulders and you stumble, may the clay dance to balance you. And when your eyes freeze behind the grey window and the ghost of loss gets into you, may a flock of colours, indigo, red, green, and azure blue, come to awaken in you a meadow of delight. In the curragh of thought, and a stain of ocean blackens beneath you, may there come across the waters a path of yellow moonlight to bring you safely home. May the nourishment of the earth be yours. May the clarity of light be yours. May the fluency of the ocean be yours. May the protection of the ancestors be yours. And so may a slow wind work these words of love around you, an invisible cloak to mind your life. An Irish blessing to you all. See you next month.